Thank you for joining us this evening to talk about dental implants. First of all, I would like to thank Dentoscope for inviting me today to speak about really what is my passion, which is dental implants. And really, I got into dentistry mainly because I really enjoyed dental implants, and that's what I wanted to learn. So let me introduce myself briefly to you before I get into the subject. And I hope that you can hear me clearly. If you don't, please send me a message and let me know if I need to change anything. So my name is Dr.Amr Bokhai. Currently I live in Jeddah, Saudi Arabia, and that's where I practice, and that's where I teach at the King Abdulaziz University. I'm an American board certified periodontist and dental implant surgeon. I graduated from UCLA School of Dentistry in Los Angeles in 2004. And then I completed a 2-year residency in orofacial pain and dysfunction at UCLA. And then after that, I continued my training at the University of Washington in Seattle, where I received my certificate in periodontics and MSD, which is a master's in dental science. And after that, I took the American board examination. I passed it. And I continued to work in the US in Seattle, and I taught at the University of Washington for 3 years. After that, I decided to come back home to my country, which is Saudi Arabia, and that's where I am now. I've been here for about 6 years. I currently practice at a clinic called Unidents with a group of 20 dentists from all specialties. I would say most of the dentists are university professors. Most of them are American or Canadian board certified. I focus most of my practice on dental implants. Of course, I do other periodontal procedures, but that's mainly what I do. So I was asked today to talk a little bit about dental implants. I know when I was a dental student, I always tried to learn from people and go to conferences and speak to periodontists and oral surgeons. And I hope that you find this brief video helpful to you. Please feel free to ask me any questions you have about our specialty, about dental implants. You may be interested in perio, you might be interested in oral surgery. I can tell you that it's a very satisfying career. I can tell you that if you like the surgical part, you're going to enjoy periodontics as a specialty. So let's start with, now I'm going to talk briefly about dental implants, but I'd like to make this more, I'd like to hear from you as well. I'd like to know what you want to hear about, so I'll be waiting for your questions as well. So first question that most people ask is, what are dental implants? So dental implants, really we owe the discovery or the progress of dental implants to an orthopedic surgeon. Actually, he wasn't a dentist. In the 1950s, he was doing a lot of research on the healing of bone cells. So his name was Brånemark, and he was in Sweden in a city called Göteborg, or Gothenburg in English. And what he used to do is he used to insert these titanium screws into rabbit bones, and at the end of these titanium screws there were these microscopes, so he could look through those microscopes and watch the cells heal. And titanium at the time, he used titanium by chance because titanium is cheap, it's a cheap material. So he tried to remove those same screws that he placed into those rabbit bones and use them in other rabbits, but he couldn't remove those screws. So basically what happened is that the bone cells attached to those titanium screws. So he came up with an idea later on to use those screws in dental implants. So this orthopedic surgeon started this company called Nobel Biocare, and it was called Brånemark. So the system was called Brånemark at the time, and then Nobel purchased the idea from him, and they started using dental implants, and then there was a lot of progress over time, and now we have multiple implant systems, maybe more than 100 companies that manufacture dental implants. So what are they? Basically, they are titanium screws that we insert in our patient's jaw, whether it's the upper jaw or the lower jaw. So we surgically insert these screws to replace missing teeth. Now, it is a surgical procedure. It takes from half an hour to up to 3 hours in some cases, where we have to place multiple implants. It's a fairly simple procedure that we use local anesthesia for 99% of our cases. We rarely have to take patients to the OR. And once that implant is placed, the process in the jawbone starts. And that process starts with a blood clot, and then the cells start to grow, which is, if you're a dental student, you know the difference between osteoblasts and osteoclasts. So there's a remodeling process, and then you get the osteoblasts producing the collagen and the bone material that attaches directly onto the surface of the implants. Now, if I try to remove that implant, maybe a week after I place it, it will easily come out, because that process hasn't completed yet, and that process is called osseointegration. So it's basically the integration of the bone cells onto the implant surface. But if you try to do that after 2 to 3 months, you're going to find that it's impossible to take that implant out. What you have to do basically is remove bone, because that implant is integrated with the jawbone now, and that's when we can load the implant. Basically, that's when we can send that patient to the prosthodontist or the restorative dentist to make the crown that connects directly onto the implant. That's called loading the implant. So we usually can't load the implant immediately. However, there are some cases when we can do that, especially in the anterior, for example, the central or the lateral. The canine, usually we try to avoid it, and the posterior we try to avoid immediate loading, because that causes a lot of pressure on the implant, and we want to make sure that implant heals before we add any pressure on it. Okay, so who can get a dental implant? Pretty much anybody who loses a tooth can get a dental implant. I'm going to get to this question. What is the best way to manage peri-implantitis? I'm going to write it down so I don't forget it. Who can get a dental implant? Anybody who loses a tooth can get a dental implant. However, we like to wait till the patient reaches puberty. So for males, usually we wait between the ages of 18 to 21, and for females, because usually they reach puberty before their male counterparts, so we have to wait till they're 16 to 18 because the jaw is still growing. So we want to make sure the jaw has stopped growing before we place the dental implant. Who cannot get a dental implant? So patients that have diabetes that's uncontrolled, so they're not taking their medications, or they have diabetes but they don't know about it. So these kinds of patients usually will get infections easily, so we try to avoid placing those dental implants in these patients until they are controlling their blood sugar. And how do we know that their diabetes is controlled? There's a test called HbA1c, and that's usually the test that we order because it gives us an average of the past 3 months. So if I test that patient today with a blood test, his blood sugar might be high, but tomorrow it might be low. So I don't know if this patient is controlled or not. So the test that we like to order is called HbA1c, and it's a very important test for all dentists to know. Now, what about smokers? Smokers usually, we can place dental implants. It's not a complete or absolute contraindication. However, the more the patient smokes, the less the success rate is going to be for that dental implant. In my practice, usually A patient that smokes more than a pack a day, I try to avoid placing dental implants in those patients because I know the success rate is going to be low. And if that implant fails, that patient's going to come and blame me, even though I told him that smoking will cause implants to fail. So we talked about when is it contraindicated. So somebody asked me about periimplantitis. That's a very good question. What is the best way to manage periimplantitis? It's very, very difficult to treat periimplantitis. It's actually, I think, easier to treat periodontitis than to treat periimplantitis. What is periimplantitis? Let's talk about that first. So basically, anything that ends with itis means inflammation or infection. So if we have periimplantitis, basically what it means is the bone around the implant has dissolved. So there is bone loss around that implant. So really it depends on how much bone loss there is. It depends on the shape of the defect. The most important thing when you're trying to graft a periodontal or periimplantitis defect is that we have enough bony walls, because that's where we're going to get our blood supply. So grafting around implants is very unpredictable. That means I can't make sure that that graft is going to be successful in most of the cases, and I always explain that to my patients. However, there are some cases where we can do a bone graft. There are different ways to treat it. Some people use tetracycline on the surface of the implants because they say that the acid or the actual antibiotic is going to kill all the bacteria that goes into the implant surface, because we all know that the implant surface is very rough. So it's very hard to clean that surface because it's rough. So the bacteria will enter that surface, and it's almost impossible to get all that bacteria off of that rough surface. So some people use tetracycline, some people graft. I've tried it all. I've seen that grafting, I'd say, again, depending on the shape of the defect, has maybe, I'd say, like a 50% success rate, which is, in my opinion, very low. In some cases, we actually have to go in, remove the implant, do a bone graft, and then go back again and place a new implant. So hopefully that answers your question. There is no best way, so that's to answer your question. Now, I get a question from some patients or some students who can place dental implants. Can a general dentist place a dental implant? I think a general dentist, if they're trained in implant placement, I think they can place implants. I know that in the US, general dentists can place dental implants. However, when you compare a general dentist who hasn't, like for example, maybe did a weekend course versus a specialist like a periodontist or an oral surgeon, I think they're probably better at controlling or dealing with the complications, because we all get complications. We all know that success rate is 98%. However, every surgeon gets complications. It's just part of our job. We have to know how to deal with the complications. So I prefer the patient go to a specialist like a periodontist or an oral surgeon, or maybe an oral implantologist, someone who took maybe a 2-year residency in dental implants. In the US, that's not a specialty. The only specialties that are basically recognized by the American Dental Association for dental implants are periodontics and or periodontology and oral surgery. So what about patients that have used bisphosphonates? Can we place implants after 5 years? The American Association of Oral and Maxillofacial Surgery has a protocol, and it's based on many studies. First of all, what are bisphosphonates? Bisphosphonates are medications that are used for patients that have osteoporosis. And what bisphosphonates do is they alter the function of the osteoclast. We all know that osteoclast is the bone cell that is mainly associated with bone resorption. So basically it alters the function of that cell and it reduces the resorption of bone in those patients. There are two ways of receiving bisphosphonates. There's the IV route, and that's mostly used for patients that have cancer, and there are also the oral route. Now, the IV bisphosphonates have a higher risk in developing osteonecrosis of the jaw. It used to be called BRONJ, bisphosphonate-related osteonecrosis of the jaw. I think they changed the name now. They changed one of the letters, I don't remember. But those patients have a higher risk. Now, when we say higher risk, I'm not talking about, 50% risk of developing osteonecrosis. I mean, the risk is still low, even in the highest risk patients. So we're still talking about maybe 1% chance of developing necrosis of the jaw. In patients that take oral, and that's most of the patients that we see with osteoporosis, they take the oral route, those patients have a much lower risk of developing necrosis. However, we still have to give them what we call a drug holiday. And again, it depends how long these patients have been taking the medications. So there's a protocol, and I recommend anyone who's interested in this subject to read about it. It's by the American Association of Oral and Maxillofacial Surgeons. It depends how long they've been taking the medications and the holiday that we give them. So basically, they have to stop the medication prior to the procedure. It's not 5 years, it's less than 5 years. I think it's 2 years, something like that. Again, and that's in not all patients, some of the patients that have been taking it for a long time, okay? I've never seen anyone with necrosis, and I know that I've heard of cases that it's a difficult condition to treat, and I hope I never see this in my practice. So why do dental implants fail? So I said that implants have a success rate of 98%. Now, why do they fail in some patients? When I tell my patients it's a 98% success rate, that means there's a 2% chance for the implant to fail. Now, if everything goes perfectly, if I place the implant perfectly, the bone is perfect, the patient is healthy, there's still a chance for that implant to fail. I can't explain it. I can't say why this patient, specifically why it failed in this patient, but I know that some patients have a higher risk of failure. For example, I spoke about diabetic patients, and I spoke about smokers. Those two patients mainly are the ones that we worry about when we place dental implants. So there is a good chance for those patients to have failures or peri-implantitis. Sometimes the problem is with the surgical procedure itself. For example, the dentist that's placing the implant maybe is not well versed with dental implantology. Maybe there's overheating of the bone. Maybe the implant gets infected before it's placed. So there are many reasons, and sometimes we can't explain why implants fail. Tips for best way to place implants in direct cases. My tip for you is there is no direct case. Sometimes I look at a case, I look at the ridge, I look at the bony ridge, it's wide, the patient is healthy. I take a cone beam CT or a CT scan, and everything looks perfect. And then you flap the area and you notice the bone is not good enough. You have to do a bone graft. So there is no direct case, but let's say there is a direct case. So I presume what you mean by direct case is the ridge is perfect. There's plenty of bone. Let's say it's a posterior. The nerve is far away. That's, to me, I would say that's a direct case. So the tip is really you just have to take a course in dental implant. If you are interested in placing implants. Now, some people do flapless placement of dental implants. I never do this. I mean, it's easier to do because you don't have to open a flap, there's no suturing. However, the problem with that is you really don't know where you're placing your implant. Is it in the bone? Is it outside of the bone? So I usually don't recommend placing flapless implants. So really my tip for you, if you are interested in implants, is to take a course by a dental implant specialist. I don't think a weekend course is enough. I think you need to take many courses before you can go ahead and start placing implants, because the complications of dental implants are a headache, and you don't want to deal with them. I'm looking at some other questions that I received. What is a sinus lift? So a sinus lift basically is a bone graft. We all know, if you took anatomy, that we have the maxillary sinus in this area here, and it extends posteriorly to the posterior teeth, and a lot of patients have those sinuses. We call them pneumatized sinuses. That means that we don't have enough vertical bone for placement of the implant. So if I have my sinus low and I place my implant into that sinus, part of that implant is going to be in air, basically. So there's nothing holding the implant. So in those cases, what we do, there are two ways to do a sinus lift. There is the osteotome sinus procedure or crestal approach, and there is the lateral window approach. The lateral window approach is a little bit more difficult, it's more technical, but it is a very highly successful procedure. And basically what we do in this procedure is we enter the sinus from the side. It's also called a Caldwell Look procedure, and a lot of ENT surgeons also use it to enter the sinus. So you create a window, or you remove part of the bone in the maxilla, and you enter the sinus. And the first thing you're going to notice when you enter that sinus is a very thin membrane. It's called the Schneiderian membrane, and it's very easy to tear that membrane. And if you tear that membrane, if let's say if it's a big tear, then you can sometimes you have to abort the procedure, wait, and then go back again. That membrane is very important to preserve, because what we do is we gently elevate that membrane and we create space inside the sinus, and then we insert our bone material, which is in the form of powder, and you can use a xenograft, which is animal product, or you can use an allograft, which is a human bone. It doesn't really matter. You can get good results with either one, but the most important thing, again, as I said, is stability of your graft, and you get that stability from that membrane that you elevated. And once we do that, we usually wait 6 months after the sinus lift before we can go in again and place our implants. Sometimes we can do a sinus lift and implant placement at the same time. It all depends on something very important called primary stability of the implant. Primary stability means when I insert my implant, it has to be stable. That means I get stability from the bone itself. Can I remove the implant? Yes, because you still didn't get the secondary stability. Secondary stability is when the implant integrates with the bone. Okay, so primary stability is very important. It's a very important issue when you are placing implants, because if you don't have primary stability, you can get implant failure. Could you please explain implant placement steps? Okay, let's talk about a direct case, for example. Let's say I'm, and I don't know what system they use in the UAE, but I'll tell you both. Let's say we want to place an implant in the 3-6 position, which is 3-6 in the European system is, I believe it's 19, I forgot what it was. I used to use the American system. Now in Saudi we use the British system, I think. So let's say it's the first molar, okay, 3-6. And we have a wide ridge, we have plenty of bone, we took a cone beam CT and everything looks perfect. So the first step obviously is to anesthetize the patient. Okay. Now, Before we talk about the actual procedure, I want to make sure that you understand that treatment planning of dental implants is the most important thing. So I never just go in and place my implants without consulting with the prosthodontist or the restorative dentist. So in our practice, we have 7 prosthodontists. So I call one of them, I say, listen, this patient wants to get an implant. What do you think? Look at the occlusion. Is there anything else you want to do before I place my implant? Do we have enough interocclusal distance? If he gives me the okay, and then after that I proceed to the next step, which is the implant placement. So after we anesthetize the patient, now when we anesthetize for, let's say, for the 3-6 position, you can either do an IA nerve, an inferior alveolar nerve block, or you can do infiltrations. You know, infiltration sometimes, most of the time, is enough if you want to place an implant. You don't really have to do a nerve block. I personally like to block. I don't want the patient to feel anything, but some clinicians, they only infiltrate. So after you make sure you have good pain control, the next step is to make your incision, and usually that incision is going to be mid-crestal. What do I mean by mid-crestal? That means you have a ridge. You want to make sure that you are in the middle of that ridge. You want to make sure that you are in keratinized tissue. I don't like to make any incisions in mucosa because it's much more difficult to suture, and the healing usually is slower. So you make a mid-crestal incision. After that, you take your periosteal elevator, you reflect the flap gently. And I say gently because you want to make sure you don't tear that flap. Once you reflect a nice flap and you have good access to the bone, you can see everything in front of you. Next step is to start your, what we call the pilot drill, and that's your initial drill. And usually, obviously it's better to use what we call a surgical guide before you place any implant. And when you have a surgical guide, usually the prosthodontist makes that for me. A surgical guide, basically I know exactly where I'm going to place that implant. It's an acrylic piece that I place, and it has a hole in the middle, and I know that I'm going directly into that hole with my drilling. And the pilot drill, basically I want to make sure I'm in the middle of that ridge, and I go in about 6 millimeters. Let's say I'm going to place a 10 millimeter implant. What I do is I go in about 5 to 6 millimeters, and then I place something called a direction indicator into that hole that I created, or the osteotomy. And once I do that, I take a periapical radiograph. And what's the point of doing that? Some clinicians don't do that. I do that for every case. What's the point of doing that? 2 things mainly. When you're drilling in bone, you really don't see where you're drilling. You don't know where the roots are. You don't know if you're going in the correct angle. You don't know where the nerve is. So you take that radiograph, you make sure you're going straight, parallel to the other adjacent roots. You want to make sure you don't hit any roots when you're drilling. And you want to make sure you're far away, in our case with the 3/6, that you're far away from the inferior alveolar nerve. Because if you hit that nerve, your patient's going to get numbness in the chin area. Once you do that, let's say you're in, you like the direction, you like the angle you're going in with, then you go down to the 10 millimeter depth with the 2 millimeter drill, which is the pilot drill. And then after that, every kit is different. I use Nobel Biocare implants or Straumann Swiss implants. Then you take it, it's very easy. You just go from one drill to another. So you start with the narrow ones, and then you move up with the wider ones. And what's the point of doing that? Why don't I just take the widest drill and I drill? Because again, something I spoke about earlier is because of you don't want to increase the heating of the bone. If you heat the bone too much, you can get bone necrosis, and then the implant will fail. And once you reach the final drill, again, it depends on the quality of bone. I don't know if you all know this, but there are 4 different types of bone. There's type 1, type 2, type 3, type 4. Type 1 usually is the densest bone, and usually we find it in the chin area. Type 2 is also dense, but not as dense as type 1, and usually we find it in the posterior mandible. Type 3 is the upper anterior, and type 4 usually is in the upper posterior. So usually success rates for implants are lowest in the upper posterior because the bone is not as dense. So let's say while I'm drilling, I'm feeling the bone. I'm feeling how dense is this bone. If the bone is really dense, then if I place my implant, it won't go all the way in. So what I do usually is bone tapping. Bone tapping, basically I'm creating the threads in the bone before I go ahead and place my implant. And then after that, I either place, now there are two kinds of dental implant placement. There's two stages, stage 1 and stage 2. Now, not every case needs 2 stages. Most cases that I do is only 1 stage. Basically, I place a healing abutment, so the implant is exposed, or the healing abutment is exposed, so the gingiva does not grow over my implant. So that after 3 months, I just take a radiograph and make sure the implant is integrated, and then I send the patient to the prosthodontist to take the impression. Now, for some patients, we place a cover screw. A cover screw, usually I do it is when in cases where I don't have enough primary stability, so I don't want any movement on my implant, or if I'm doing a bone graft simultaneously with my implant placement. So this is a 2-stage procedure because I place my cover screw and I cover the gingiva over my implants. Now, I don't have access to the implant after 3 months, so I have to do the 2nd stage, which is I open another flap, I remove the cover screw, and I put a healing abutment instead of the cover screw. And then I wait another week for healing of the soft tissue, and then I send the patient back to the prosthodontist or the restorative dentist to take the impression. Patients with implants and ortho treatment, it's not preferable, but how to manage this? We place implants in patients who are going through ortho treatment. Usually, in most cases, we wait for the ortho treatment to be completed because, as we all know, with ortho, the spaces are going to change. So I want to make sure that the space is not going to change before I go ahead and place my implants. However, in some cases, the orthodontist sends the patient back to me so I can place my implants before they're done with ortho treatment. Again, every case is different, but it's not a problem to place implants in patients who are having ortho treatment. Sometimes patients require bone grafts, so we do the bone graft before the ortho is completed, and then we wait 6 months, they complete their ortho, and at the same time the bone is healing, and then we can go in and place our implants. There has to be coordination between the implant surgeon and other specialists like the orthodontist. It's very important. Now, can we place implants for a patient that has periodontitis? The answer is yes and no. We can place implants for patients that have had periodontitis, meaning that if I have a patient that has periodontitis, first I have to treat the periodontitis. I cannot go in and place an implant in a patient that has active disease because that implant will likely fail. So first we have to treat the periodontitis. In some cases we have to go through osseous surgery or open flap debridement, and then once that's controlled, then we can go ahead and place our implants. Why do we need to follow up with our patients? We have to follow up with not just our dental implant patients, but we have to follow up with all our patients, and that's why we have maintenance schedules for our patients in our clinic. So every 6 months they have to come in and do cleaning. At the same time, if they have a dental implant, sometimes we take a periapical radiograph to make sure that there is no periimplantitis, that they are cleaning the area well. It's basically to avoid any complications down the road. Dental implants are expensive. It's not a cheap procedure, so we want to make sure that that patient is taken care of. We want to make sure that that patient knows how to clean the implant, so that, again, we don't have any complications. We don't have to deal with it down the road. I don't have to deal with it as a implant surgeon. I don't have to remove it. I don't have to go through that. So it's very, very important to follow up with our patients after we place our implants. Are there any other questions, or should we end it here? I think that should be it. I hope that it was helpful. I'm always available. If anyone has any questions, you can send me on Instagram. Best type of implant. Best type of implant, well, there are many companies that manufacture implants. As I said earlier, maybe more than 100 companies. Some Korean, some German, some French, some Italian. I basically like to use 3 kinds. I've tried many of them. I prefer Nobel Biocare, which is Swedish, and Straumann, which is Swiss. Prima is American, made by Dentsply. But I'd say 90% of my cases are Nobel Biocare. I can't say what's the best type of implant. All titanium integrates. Doesn't really matter. I think what's more important than the type of the implant is how the procedure was done, the treatment planning, the coordination between all the specialists, the patient's compliance. I think that's really more important than the type of implant. Now you have zirconia implants, so anything that integrates, it's going to be good. Some restorative dentists prefer certain type of implants because the restorative parts are easier to deal with. But for me, as the surgeon, it really doesn't really matter. It's just what you're comfortable with. For edentulous patients, how many implants will we place per arch? That's a good question. In our clinic, we do a lot of immediate loading of edentulous patients, edentulous cases. For example, I get a fully edentulous patient and I go ahead and I place, usually in the maxilla, I place between 6 to 8 implants, and in the mandible, minimum 5 implants. And why do I need more implants in the maxilla? Because, as I said earlier, the bone is denser in the mandible, so I need less number of implants. In the maxilla, I need a higher number of implants. So usually I go for 8 implants in the maxilla and about 6 in the mandible. And do I have to have 8? Sometimes an implant fails, so at least if an implant fails, now I have 7. I don't have to go back and do another one. So 8, I would say, is a good number for the maxilla, and 6 for the mandible. What do I mean by immediate loading for these cases? Now, there are a lot of cases that come to us that are fully edentulous and they want fixed prosthesis. They're tired of the dentures that they're unstable, they can't eat with them. So what we do for these patients is I place the implants, and immediately after that the prosthodontist comes in and he connects a provisional fixed prosthesis onto the implant. So they walk in without teeth, or they walk in with badly decayed teeth, and they walk out with a nice fixed prosthesis. It's really one of the nicest procedures we do. It takes maybe 3 hours to complete the whole thing, a full arch. So usually we do 1 arch, and then the following week we do the lower arch, for example. So these patients really appreciate what we do for them. For edentulous patients, if we place for upper first molar, do have to place lower first molar as well. Again, treatment planning is one of the I would say is the most important thing when you are placing implants. What's the point of placing first molar in the upper if you don't have occlusion on the lower? So we're not really achieving anything. So if you have a tooth hanging in the upper, in the maxilla, and the patient's not using it, then it's useless and they just spend money for nothing. So yes, usually if you're placing an implant in the maxilla, you have to make sure that implant crown is going to be in occlusion. Otherwise, you're wasting your time and the patient's money. I think that should be it for tonight. I hope you enjoyed it, and I'm happy to again answer any of your questions. If anyone is interested in this subject, please feel free to send me your questions. Again, I want to thank Dentoscope for having me tonight, and hopefully we'll see you again, and have a good night.